Welcome to vpod.ai, and thanks for joining us for another deep dive.
Glad to be here.
Today, we're going to get into a topic you might not hear about as often as melanoma, but it's really significant. We're talking about Merkel cell carcinoma.
Right, MCC. It's rare, but surprisingly aggressive.
Exactly. And there have been some really interesting developments, challenges too, but also breakthroughs.
Definitely.
Before we really dive in, though, we want to give a big shout out to our sponsor, Stonefly.
Yeah, absolutely.
This deep dive is brought to you by Stonefly. They're your trusted solution provider and advisor for all things enterprise storage, backup disaster recovery, hyper-converged setups, think VMware, Hyper-V, Proxmox clusters.
And AI servers too, right?
Yep, AI servers. SA365, that's a turnkey security appliance in public and private cloud solutions. Lots of ground covered.
For sure. Check them out at stonefly.com for more info.
Okay, so let's unpack this. Merkel cell carcinoma. What exactly is it?
What starts in these cells called Merkel cells. They're kind of fascinating, actually. They're neuroendocrine cells. So they have features of both nerve cells and hormone-producing cells.
Okay.
And you find them deep down in the epidermis, the skin's top layer, right near nerve endings involved in touch sensation.
Interesting. So it's a skin cancer, but from these specific cells.
Precisely. And here's the kicker. While it's way less common than, say, basal cell or squamous cell carcinoma, it's actually the second most common cause of death from non-melanoma skin cancer.
Wow. The second. That's disproportionate for its rarity.
It really is, and the numbers are climbing. Data from the SEER registry showed its incidence basically tripled between 1986 and 2001.
Tripled.
Yeah, that's about an 8% increase per year. Compare that to melanoma, which was rising about 3% annually during that same time.
An 8% annual jump is pretty steep. So the big question is why? Is it just we're getting better at finding it, or is something else going on?
That's definitely a key question. Better detection probably plays some role, sure. But the bigger factors seem to be, well, demographics and immune status. We're seeing more people with suppressed immunity.
Like organ transplant patients.
Exactly. That's a big one. And also, just the fact that our population is aging. Elderly people are at the highest risk.
Right. It mostly affects people over 50, I read, especially over 70.
That's right. Particularly fair-skinned individuals and slightly more often in men.
So for you listening, understanding the why here is important. Like most skin cancers, UV rays are a major culprit, right? Sun, tanning beds, damaging skin cell DNA.
Absolutely. UV damage is a factor. But with MCC, there's this really interesting viral connection too.
Ah, yes, the polyomavirus.
Exactly. The Merkel cell polyomavirus, or MCPYV. About 80% of MCC cases are linked to it.
And this virus is common.
Extremely common. Most people get it in childhood, usually with no symptoms at all. It just sort of hangs out.
So how does a common harmless virus suddenly cause cancer?
Well, the current thinking is that if your immune system is weakened for some reason, maybe due to age, illness, or medication, it can't keep the virus in check properly.
Okay.
And in some cases, the virus then seems to trigger the production of a protein in the skin cells that basically messes with the cell's natural off switches for cancer. It turns off tumor-suppressing genes.
Wow. So a combination of factors, UV damage, maybe this virus reactivating in the context of a weakened immune system.
That seems to be the picture. Other risk factors sort of tie into that.
Yeah.
Having other skin cancers before, using tanning beds, even certain light therapies for skin conditions.
And things that directly weaken the immune system, like certain leukemias, HIV, or immunosuppressant drugs.
All significant risk factors. And diagnosing it, as you mentioned, can be tough because it doesn't always look like anything specific.
Yeah, that's tricky.
There is a helpful acronym, though, that covers the common signs. It's AEIOU.
AEIOU, like the vowels.
Yeah, exactly. It stands for asymptomatic, meaning it usually doesn't hurt or itch initially. Expanding rapidly, often growing noticeably in under 3 months.
Okay.
Immunosuppression, having a weakened immune system.
Yeah.
Older than 50 years. And UV-exposed skin showing up on places that get a lot of sun.
Got it. AEIOU. That's useful. So what does it look like typically?
It usually pops up on the face, neck, arms, sometimes eyelids, those sun-exposed areas. It can be a firm, dome-shaped lump.
What color?
Often skin-colored, but it can also be reddish, purple, or even bluish-red. Sometimes it's shiny or pearly looking.
And it grows fast?
Very fast, often. It can get to the size of a dime pretty quickly. Sometimes it might feel a bit itchy or tender, and it can even break open and look like a sore that won't heal.
Given that it can look like other things, seeing a specialist is key then.
Absolutely crucial. A dermatologist knows what to look for. and can tell it apart from, a harmless cyst or even an insect bite gone wrong.
What's the first step in diagnosis usually?
It starts with a really thorough full-body skin exam. The doctor will also feel for any swollen lymph nodes, particularly near the suspicious spot, as that can be a sign of spread.
And if they see something concerning,
Then you need a biopsy. That's the only way to know for sure.
what kind of biopsy?
Ideally, a punch biopsy or an incisional biopsy, something that gets a deep enough sample right down through the dermis into the subcutaneous fat. You need the full thickness.
And what are they looking for under the microscope?
MCC has a distinct look pathologically. The cells often have what's called salt and pepper, chromatin. The genetic material looks speckled, and they don't have much cytoplasm, the cell's filling.
Sounds specific.
It is, but to be absolutely sure and to rule out other similar-looking cancers like small cell lung cancer metastasis or lymphoma, they use immunohistochemistry.
Those special stains.
Right. MCC cells typically stain positive for specific markers, like cytokeratin 20, often in a sort of dot-like pattern, and neuroendocrine markers like synaptophysin. That really nails the diagnosis.
Okay, so diagnosis confirmed, then you need to know if it's spread, right? Staging.
Exactly. Staging is critical for planning treatment. And for that, we use imaging.
Like CT scans.
CT scans, yes.
Wow.
PT scans are often used too. They can show metabolic activity, which helps find cancer spots. And MRI.
MRIs is good for...
Really good for soft tissue detail. So it's particularly valuable for seeing if the cancer has invaded nearby structures. And it's very helpful for planning radiation therapy, precisely.
Makes sense. I've heard about sentinel lymph node biopsy too, SLNB. How important is that?
Oh, very important. It's designed to find microscopic amounts of cancer in the first lymph node, or nodes, that drain the area of the primary tumor.
The sentinel nodes.
Exactly. Because MCC often spreads to lymph nodes early, even when they don't feel swollen. SLNB can pick up this occult disease that clinical exams and even CT scans might miss.
So it helps get the staging more accurate.
Hugely more accurate. Some consider it a diagnostic gold standard for nodal staging, though it does require surgical expertise.
And if it's positive, if there's cancer in the sentinel node,
that changes things. It means the cancer has started to spread, and it guides the decision to give adjuvant therapy, extra treatment after surgery, usually radiation to the lymph node basin.
to improve outcomes.
Studies show it leads to longer relapse-free survival. So yes, sometimes they might do a fine needle aspiration, FNA, of a suspicious node too.
Got it. And all this staging information gets put into the AJCC system, the TNM thing.
Right. Tumor, node, metastasis. It categorizes the cancer from stage 0, which is just in the very top layer of skin, all the way up to stage 4, where it's spread to distant organs.
Higher stage means more advanced.
Correct. Stage 1 is a small tumor, hasn't spread. Stage 2 might be larger or invaded deeper locally. Stage 3 means it's reached the regional lymph nodes. And stage 4 is distant metastasis. Knowing the stage is fundamental for deciding on treatment.
So let's talk treatment. Once it's diagnosed and staged, what are the main approaches? Sounds like a team effort.
Definitely multidisciplinary. Surgery is usually the first step for the primary tumor.
Cutting it out.
Right. Prompts a surgical removal with clear margins, meaning taking out a border of healthy tissue around the cancer to make sure you got it all. For early stages, that might mean 2 or 3 centimeter margins.
Okay.
Sometimes if they're doing an SLNV, they might do that first and then do the wider excision once they have the node results.
Makes sense. What about after surgery?
Radiation therapy, or RT, plays a huge role. MCC is known to be highly radiosensitive.
Meaning it responds well to radiation.
Exceptionally well. Guidelines strongly recommend radiation after surgery to the primary tumor site. It significantly boosts local control rates, preventing recurrence in that spot and improves survival.
Even for small tumors.
Yes, often regardless of the initial tumor size. Radiation is also frequently given to the nearby lymph node areas, especially if the SLND was positive or if nodes couldn't be assessed.
Can radiation ever be used instead of surgery?
In some situations, yes. If a patient isn't a good candidate for surgery, radiation can sometimes be used as the primary treatment. And it's definitely used to treat metastatic disease, often to relieve symptoms like pain from bone metastases.
Okay, so surgery and radiation are the mainstays for local control. But you mentioned this cancer is aggressive. What about treatments for when it spreads? Systemic treatments?
This is where things have really changed. Historically, chemotherapy was the go-to for advanced or metastatic MCC.
How well did that work?
Honestly, not great long-term. Chemo could shrink tumors sometimes, but the responses were usually short-lived. Most patients would see their cancer start growing again within about 90 days.
That's discouraging.
It was. But now we have immune checkpoint inhibitors, immunotherapy, and it's been a revolution for MCC.
How do they work?
Basically, they work by releasing the brakes on the patient's own immune system. They block certain proteins like PD-1 or PD-L1 that cancer cells use to hide from T cells.
So the immune system can then recognize and attack the cancer.
That's the idea. It unleashes the body's own defenses against the tumor.
And this is standard now for advanced MCC.
Yes. Drugs like avelumab,
Yeah.
pembrolizumab, they've got FDA approval and are now the first-line standard of care for metastatic or locally advanced MCC that can't be treated with surgery or radiation alone.
What kind of difference has it made?
A huge difference. Remember how maybe only 5% of patients got a lasting response from chemo? With these immunotherapies, we're seeing durable, sustained benefits in around 50% of patients.
50%, that's a massive leap, a real game changer.
It truly is. It's completely changed the outlook for many patients.
But what about the other 50%? What if the cancer doesn't respond to these first-line immunotherapies or it stops responding?
That's still a major challenge, absolutely. It's called having refractory disease.
So what are the options then?
For patients whose cancer progresses despite those initial anti-PD-1 or anti-PD-L1 drugs, one approach that's shown some promise is adding another type of immunotherapy called ipilimumab. It targets a different checkpoint, CTLA-4.
Combining immunotherapy.
Exactly. Some studies suggest this combination might work in about 31–32% of those difficult-to-treat cases.
That's something, but still leaves a lot of patients needing other options.
It does. And that combination can also come with a higher risk of significant immune-related side effects. We need to manage those carefully.
So there's still a big need for new approaches.
Definitely. Clinical trials are absolutely crucial here. Researchers are looking at things like triple checkpoint blockade hitting multiple immune pathways,
Okay.
or combining immunotherapy with other strategies like peptide receptor radionuclide therapy, PRT.
What's that?
PRRT uses a molecule that targets receptors found on many MCC cells, and it carries a radioactive payload directly to the tumor, sort of like a smart bomb. Combining that with immunotherapy is being explored.
Fascinating. And where does chemotherapy fit in now? Is it still used at all?
It's generally moved further down the line. It's mostly reserved for a palliative role now.
Meaning for symptom control.
Right. Typically used if immunotherapy has failed or if someone can't receive it for some reason. Its long-term effectiveness just doesn't compare to immunotherapy for most patients.
Okay, so treatment has advanced incredibly. But what's the overall outlook? You mentioned it can come back?
Yeah, recurrence is unfortunately common, but 40% of patients experience it, usually within the first 2 years after treatment.
And survival rates. They depend heavily on the stage at diagnosis.
Very much so. If it's caught early, just localized disease, the 5-year survival rate can be up to 80%. It's pretty good.
But if it's spread?
If it's reached the lymph node stage 3, the 5-year survival drops, maybe into the 35% to 60% range. It varies. And if there's distant metastasis, stage 5, sadly, it's much lower, historically around 14% to 25%.
Those numbers really highlight the importance of early detection and effective treatment.
Absolutely.
Though there was that one surprising finding you mentioned earlier about tumor size.
Oh, right. Yeah, it's quite counterintuitive. Research suggests that the actual size of the primary tumor when it's diagnosed doesn't seem to correlate with the risk of relapse later on.
So someone with a larger initial tumor doesn't necessarily have a worse prognosis in terms of recurrence.
Based on that data, no. Which can be somewhat reassuring, I think.
Yeah.
Other factors seem more important for prognosis.
Like what?
Like the Merkel cell polyomavirus status, whether the tumor is positive or negative for the virus, seems to have implications, though it's complex. And, crucially, the patient's overall immune system strength.
A stronger immune system means a better outlook.
Generally, yes. A robust immune response is associated with better outcomes, which makes sense given the success of immunotherapy.
Okay. So given everything we've talked about, the risks, the aggressiveness, what are the key prevention takeaways for listeners? What can people do?
Prevention really comes down to sun protection. It's the cornerstone.
The basics, but they matter.
They matter hugely. Use broad-spectrum sunscreen. SPF 60 is often recommended now. Apply it daily, even on cloudy days, and reapply every 2 hours if you're outdoors.
And avoiding peak sun.
Definitely. Try to limit direct sun exposure between 10 a.m. and 4 p.m. Seek shade. Wear protective clothing, wide-brimmed hats, sunglasses, long sleeves if possible.
And tanning beds.
Just avoid them. Carry it.
Well.
Tanning beds and sun lamps significantly increase risk.
What about self-checks?
Really important. Get to know your own skin. Learn how to do regular skin self-exams, maybe once a month.
Looking for.
Anything new, changing, or unusual, especially any new lump or spot that seems to be growing quickly, or maybe itches or hurts. If you see anything like that, don't wait. Get it checked by your doctor or a dermatologist promptly.
Early detection is key.
It makes a world of difference with MCC.
Now, a lot of these insights, especially around treatment effectiveness and prognosis, come from research studies. But you mentioned MCC is rare. Does that pose challenges for research?
It absolutely does. That's a really important point. Because it's relatively uncommon, it's very difficult to conduct large randomized controlled trials, the kind that give the highest level of evidence.
So where does much of the data come from?
A lot of what we know comes from combining data from smaller studies or looking back at patient records retrospectively. These are called meta-analyses or retrospective studies.
And those have limitations.
They do. They can be prone to biases like selection bias, maybe only certain types of patients were included, or inconsistencies in how data was collected across different centers.
So we need to interpret the results with some caution.
A little bit, yes. It means that sometimes the effect size, how much benefit a treatment shows, might look a bit smaller in a future large randomized trial compared to these earlier studies. But the overall direction, the trends, like the huge benefit of immunotherapy, that's very clear and consistent.
And there are dedicated efforts to push research forward.
Oh, yes. There are collaborations like the Merkel Cell Carcinoma Collaborative Institute, MC3, and others globally. They bring researchers and clinicians together to pool resources, share data, and run trials more effectively for this rare cancer. That's really driving progress and offering genuine hope.
That collaboration sounds vital.
It's essential for rare diseases.
So wrapping this up, what's the big picture takeaway for our listeners?
I think the story of MCC is actually quite remarkable. It went from being this poorly understood, very dangerous cancer with limited options to one where we've seen truly rapid progress, especially with immunotherapy.
It really highlights the power of targeted research.
It does. And it also underscores that ongoing need for vigilance about our skin health, knowing the signs, protecting yourself from the sun, and getting things checked early.
Absolutely. What can you, our listener, do with this knowledge?
Well, first, be aware. Don't ignore changes in your skin, especially something growing fast. Talk to your doctor.
Be proactive.
Exactly. And understand that even for rare cancers, research is constantly moving forward and treatments are getting better.
That's a hopeful note to end on regarding the science. And speaking of support, a huge thank you again to Stonefly for sponsoring this deep dive.
Yes, thanks to Stonefly.
And remember, if you're looking for enterprise IT solutions, they have that fantastic offer right now. A 100 terabyte immutable and air-gapped SSO NAS for just $8,995.
Wow, that's a lot of secure storage.
It is. You can find out more about that and all their other solutions at stonefly.com.
Definitely worth checking out.
We really hope this deep dive into Merkel cell carcinoma has given you some useful insights, maybe some surprising facts, and helped you feel more informed about this rare but important condition.
Hope so too. Keep asking questions.
Until next time, keep digging deeper.